Currently what we do is a combination of different treatments. Many places in the world do what's called TURP, which is transurethral resection of the prostate, and this involves cutting out small slithers of prostate tissue with a fine tungsten wire. And we've been doing that for 70 or 80 years, but the trouble with that is there is quite a lot of bleeding involved. We have developed laser technologies at this hospital, which are now utilised all around the world, which cut down on the bleeding and shorten the patient's hospital stay. But there still is a need for what we call a minimally invasive technique, which can be standardised, can be automated, and in this case involves a unique and groundbreaking technology called aqua ablation. It's envisaged that this type of surgery will undergo a pilot evaluation, which is what we are doing here. This is the first place in the world that is utilising this technology on live patients. Assuming that the pilot study is successful, then we'll go on to what we might call a phase 2 study, which is multiple centres utilising the technology and evaluating it and seeing if the results that we achieve here are reproducible in other sites. And then, of course, we can compare it to the gold standard, which might be either a laser procedure or the transurethral resection of the prostate, which is the standard BPH technique from the past. And all that takes time, so I would imagine it will not be available for use outside of a clinical trial for some years, but that's the sort of lifespan of these technologies. They often take quite a few years from benchtop to patient, and then from patient to regular in-practice use. Well, there are hopefully going to be both patient benefits and hospital benefits. The hospital benefit with a device like this is that we're going to be able to achieve finally an automated, standardised result for patients. The automated robotic arm, which is carefully calibrated to the measurements of the prostate, will deliver a uniform result every time. The advantages to the patient might well be that because there's less thermal injury to the tissue, then there may well be significantly less urinary side effects after the surgery, and particularly we're thinking more of symptoms such as irritation, urinary irritation, having to go to the bathroom more frequently, urinary pain and so forth, which patients sometimes get for a variable length of time after this type of surgery. We're also hoping that the surgery will be shortened ultimately once the technology has been ironed out and becomes standardised. And so all in all, it should be something of interest to both hospitals and surgeons, and most importantly patients.